Well, hello, and glad to be back here once again. Welcome back, everybody, to the Mental Health Show, where it's obvious what we're talking about here. But when we say mental health, there's a lot of subcategories that are attached to mental health, and that's why we're continuing on here. Episode number 7. We've had a great response. Thanks to all of you who have been watching, and we hope you're getting lots of value out of these episodes that we're bringing to you. And again, today, another unique conversation. And again, I'm just the guy that brings them on. I'm not the expert. We're bringing the experts on here now to talk with us. Welcome, ladies. Thanks for being here.
Thank you.
Thank you.
Thanks for having us.
Yes, you heard me say it's been very impactful to have this the mental health show here, and good information. And we're going to share more of that today. But let's go around the table and get everybody introduced so everybody knows who we're talking with. And we'll start. Libby Ells, we'll start with you.
Hi, so yes, Libby Ells. I'm a social worker at St. Clair Child Youth Services and clinical team leader, actually. Been working in the area of mental health with post-MSW for about 20 years, probably.
Fantastic. So you'll have lots to share as well. Thanks. And Cheryl Czyczurko, I got that right, did I?
Yes, you did.
Yay, right on. Okay.
I'm also from St. Clair Child Youth Services. I've had 8 years I've been here. I also worked at the Community Girls Home for 17 prior to receiving my Master's of Social Work.
Very good. And Kelly McGregor.
Hi. So I am a withdrawal management worker here at Bluewater Health Services. So I've been working in frontline addiction care for about 11 years. Primarily within withdrawal management services. So I originally came from London, Ontario. When the new facility opened up at Bluewater Health, I came here to help kind of begin that new journey in this new program. So I began in the residential program where I worked primarily in that acute setting for 11 years. And then now, because we're community and residential withdrawal management, I am community withdrawal management worker as well. So, yeah.
Very good. So as I mentioned, folks watching, we've got the experts here today. And now, what are we talking about? I look at my notes in front of me, and Cheryl and Libby, I'll probably start with you on this one. A lot of times in these discussions, there's big words, or what do these words mean, right? Concurrent disorders. I think the word disorder is probably understood, but explain those two words together. Maybe, Libby, you want to start off.
Sure. So Cheryl and I are in the Concurrent Disorders program at St. Clair Child and Youth Services. And concurrent disorders is just a word that we use to describe what's happening when someone is experiencing both a substance use issue and a mental health issue. We may never figure out which came first, and that doesn't matter. The key is treating both at the same time.
Very good. Cheryl, did you want to add anything to that?
Well, there's also different models for understanding how concurrent disorders develop. Sometimes the mental health might come first, depression and anxiety, and then kids will be using to combat those mental health issues. And sometimes the substance use comes first, and then we have the mental health of anxiety or depression that follows that. So like Libby said, we don't know really what comes first. Sometimes we can guess it. Sometimes the client will tell us, but yeah.
Right. So take us through the process of, kind of like the first point of contact with a client who would use your services for this. Take us through that process and then how it continues on.
Do you want me to do that, Libby?
Whatever you want.
Okay. The first point of access is a parent or a client or youth can call into the agency. They'll be directed to intake, and intake will ask them a bunch of questions, and then they don't even have to wait. Libby or I will be in contact with the client once we get the information from the intake office.
They might, I'm going to add to that. Yeah, they may also show up at our walk-in therapy clinic, or they may come over as a brief crisis referral from Bluewater Health. If young people are identified as potentially having a concurrent flavor, we kind of say, they are assigned to Cheryl or me as quickly as possible. They're at greater risk of harm on a number of different levels, and so as much as possible, we don't want them to wait to start to see someone.
Right. No, that's a good point that you bring up, the wait, and it's a good opportunity to clarify some things to the public, because, you often hear, oh, you got to wait, months and months and months or years. I've heard all kinds of stories, right? Can you kind of clarify that a little bit on your end of what would be kind of an average wait time for somebody to get the assistance they need from you?
Do you want to go ahead, Cheryl, or do you want me?
Well, wait at St. Clair Child and Youth Services. There's always the walk-in clinic where you don't have to wait. You just attend the walk-in on the days that they are. You get a single session therapy. As for the concurrent kids that could come to the walk-in as well. But if they're doing a call-in, or if it comes from Bluewater Health, it takes few days for us to get into contact with them. Yeah. I don't want to give an exact number. We might be on holidays or whatnot. But so they wouldn't wait any longer than 2 weeks for Libby and I to get in contact with them.
Yeah, and that's I'm glad we shared that, because as I'm sure you hear too, that there's always these long waits, but it's based on case by case for sure, right? So depending on the urgency. Kelly, I want to bring you into the conversation. Thanks for being here. And I've already heard the word addiction in here. What classifies as an addiction, and how does it relate to mental health?
So it's a pretty broad question. It's not typically a black and white answer. CAMH has some pretty great resources on kind of how they talk about what an addiction is. So it's often used to refer to any type of behavior that is out of control in some way, or is kind of seen as a series of maladaptive behaviors. So for example, with social drinking, so it might be just social experimental use, leading to a series of maladaptive behaviors. For example, cravings, loss of control of the amount or frequency of use, the compulsion to use, and also the compulsion to use despite any type of serious consequences as well. So they kind of look at the 4 C's when you talk about addiction, and what they kind of look at the continuum of use, from experimental to dependency. So as far as it being related to mental health and that concurrent disorders and what came first, so it is connected. So they say that often about 50% of people with substance use disorders also have experienced a mental health problem at some point in their life. So people may turn to certain substances as a way to cope with the different emotions or situations that have led up to their substance or their addiction. So they start to use to regulate those emotions, because when we're using to stimulate that part in our brain that feels good. So that stimulation of dopamine. So that use is immediate, that reward as well. So it's that associated with that reward and pleasure. So it helps to kind of keep within that window of tolerance, despite the use, despite the consequences of the use, I should say.
Okay, so are you saying, just to clarify, so is addiction a mental illness?
So technically it is. So it is classified in the the Diagnostic and Statistical Manual of Mental Disorders, also known as like the DSM-5. So you can look up that information. So there's tons of information online as far as what the DSM is and the DSM-5. So the DSM does recognize that not all people are automatically or equally vulnerable to developing a substance use disorder. So according to the DSM-5, some people have lower levels of self-control because there are those predisposed conditions and circumstances that allow them to develop problems if they're exposed to any substances. So the DSM-5 has two different groups of substance use disorders. So they have substance use disorders and substance-induced disorders. So just to kind of give a brief description of it, again, all information is online because it's quite a big manual to go through. So the substance use disorders, so it's a pattern of symptoms, like we talked about before, resulting from the use of substances that you continue to take despite experiencing problems as a result. So substance induced disorders, so includes intoxication, withdrawal, or other substance or medication-induced mental disorders that are kind of detailed alongside substance use disorders. So it is technically classified as like a mental illness.
Okay. Now, let's take this a little bit further now, and we'll go a little deeper into this because we always, on all the episodes, we've talked about stigma, and that's attached to mental health. And you could talk to some people that, like you mentioned, social drinking, for example. How does one know that? I guess how do they know they need your services? How do we recognize, that is social drinking a problem? Like lots of people go out and have drinks, and when does it become a problem and we know it's an addiction? Who wants to jump in on that?
So the good news is that most adolescents who use substances do not progress. Whoops, lost. Oh no.
That's okay.
Don't progress. Yeah, they don't progress to problem use. We do know that young people have a higher rate of addiction than adults, and part of that is because the frontal part of their brain, the part that controls things like executive function, making good decisions, ability to plan and reason, make good decisions, learn from experience, not fully developed usually until young people are 24, 25 years old. But we do recognize that they're at a higher risk of addiction, and that the consequences of addiction can be worse for young people than it is for adults. Just kind of adding to what Kelly said, the World Health Organization does recognize that if someone has an addiction, they have a mental health issue. I tend to keep away from the word addiction, and I think that that's related to that whole idea of stigma, Dave, right? We are, the people that we're seeing in our practice are maybe not functioning in their lives as well as they would like. So they might be failing at school, they might be suspended from school, they might be missing work, their relationships might be suffering. And I think these are the indicators that they might need services like ours in their lives.
Yeah. So, okay. But who recognizes that? Do I recognize that in myself? Right. Because, I don't have a problem. What are you talking about? I don't need your help, especially, well, I don't want to label, but I guess all ages really would have a problem admitting to that, So how do they get the help if they don't realize they need the help, but they probably really do? Is that a fair question? That's probably a tough question.
That's a really good question. Can I answer that?
Yeah, good question.
So sometimes even the parents, they'll start recognizing little things that are happening, kids coming home with different symptoms, and teachers as well, the community, any extracurricular activity, their coaches might be recognizing irritability, lots of different things. And so sometimes those people will come to us and have a conversation with us, and hopefully that we can engage the kid to come in and maybe through counseling recognize that they are not functioning at where they should be.
Mm-hmm. So, and Libby, you mentioned that word. You don't like to use that word addiction. Do we avoid the word normal as well these days? Like, what's
Absolutely.
normal?
I have no idea. I have no idea what normal is.
Especially
There's yeah, such a broad range. And so I don't know, I guess I tend to use words like what's typical or what's typical for you or things like that. Yeah.
Yeah. Now, anybody can jump in on this one as well, but because you're all kind of in unique positions here, so it's nice to get a crossover of opinion. COVID-19 is certainly, you can't go a day without hearing that word, and unprecedented and all that sort of stuff. Kelly, maybe I will start with you over at Bluewater Health. Have you seen more use in services from Bluewater Health because of COVID-19?
Yeah, so interesting enough, really. So kind of at the very beginning of it all, we saw a bit almost of a halt and it started like a decline in services for about 2 weeks, maybe, when everything was starting to come up and precautions were being put up and people were not really too sure kind of where to go. So we did notice like a slight decrease in service. And it's great because I work in the residential and community services. So we've seen like the break in the services and also the increase in services actually after about 2 weeks into COVID. So as the community began to kind of adapt to that mandatory isolation and recognizing that our stress tolerance and our coping skills and our coping strategies that we have worked on, whether we have substance use in our life or not, is not pandemic ready. And so we began to really notice an increase after that mandatory isolation began in our services because that stress tolerance was lowering and a decrease in coping mechanisms into adjusting to something that you haven't experienced again before. And so our conversations really were about, okay, so how do I adjust during this pandemic? But now that my support systems almost feel like they're cut, how do I reach out and what services are available to me? How do I continue to meet with you? So we did notice that there was an increase in our services because of that. And so because of that increase, so our stats, I believe, I think almost like tripled maybe during like since the pandemic kind of began with us that we noticed. So it kind of reinforced our need for services and to maintain that crisis support. So we maintained that like walk-in services. We then adjusted to that need to, my counselor is, that important piece to my well-being. So how do we adjust to it? So we integrated virtual options for treatment, virtual options to stay connected to your community. Because really that's what it is that having that sense of community and understanding. So we definitely have noticed like that increase during COVID.
Right.
I,
And
can,
Cheryl,
I wonder if I can, could I jump in for a sec?
yeah, absolutely, absolutely.
I'm just thinking that for us, maybe it depends a little on what the particular mental health concern is, because for some of our clients, the environment that causes anxiety is the school.
Mhm.
And as soon as they're away from school, which they have been for several months, the anxiety decreases. And so maybe if they're using substances as a coping strategy, that's not as necessary anymore. In what we have found in our practice is that there is a lot of correlation between substance use and trauma. And trauma is not going to go away based on whether you're in school or not. Trauma's with you. So that's kind of interesting. I did a little bit of a survey on my clients couple of years ago, and I found that like 65% of them had experienced a traumatic event, whether or not they identified it as trauma. They identified an event that might be considered traumatic. So really high correlation there.
Right. And on the St. Clair Child and Youth Services side, do you kind of echo what Kelly said as far as that time frame really got quiet for a little while, and then all of a sudden it got busy again, or did you see something different there?
I just am busy, whether it's pre-COVID or post-COVID. It just seems like there's always kids, parents to be in contact with. And I don't do the stats, so I don't know whether we're higher or lower personally. I just know with the school, there's not a lot of eyes on these kids, and they're out there on their own, which is a big concern for me.
Yeah. What about you talk about addiction, and I guess we're kind of specifically talking on the youth side of this. What about access to these things? Access to the drugs, access to the alcohol. Like, you're supposed to be a certain age to get that stuff, and some of that stuff you're not supposed to get at all. Is that something that is that part of the conversation and the process in trying to overcome? Is we got to change who we hang around with and all that. Like, stay away from deal with that side of it.
Sure. So treatment goals may include reducing the risk of returning to substance use, or finding ways to live a healthy life. And often the environment, the people that you're hanging out with, they can be triggers for substance use. Absolutely. Access is not a problem in our community. Would you guys agree with that? Yeah. We've had the Sarnia police come and present to us, and they're seeing locally lots of crystal meth and opiates and cocaine. And in our practice, I think Cheryl would agree that we're seeing lots of young people who are using marijuana and alcohol. Some who are using opiates, some who are using crystal meth. They're using MDMA, they're using cocaine, they're using mushrooms. Yeah, the access is not an issue. So definitely conversations about that are important.
Mm-hmm.
Yeah. Now, you mentioned a lot of different drugs and a lot of different, like when I was in high school, there was like 1, 2, 3, or 4. Now there's one for every letter of the alphabet and then some. But the two that you mentioned in there, Libby, just now was alcohol and marijuana. And this is just an observation from conversations that I've had around. We don't seem to take alcohol and marijuana that serious as we did, say, 20 years ago, as far as in the public or community eye. Would you agree with that?
I don't know if I would agree with that.
Or we treat it differently?
I don't know if we, being the 4 of us, treat it differently, but I know that I've heard from clients who say, oh, like weed isn't even a drug, right? It's natural. I think that that's a pretty common thing. Well, weed is a mood altering substance, right? And we treat it like that because regardless of whether it is a drug or not, we know that it's illegal for young people to use, and that there could be implications of that use on them. It's interesting because there's this thing called the Ontario Student Drug Use Health Survey. It's put out by CAMH every 2 years. So we have the results from 2019. And it's interesting because there's a downward trend in use of alcohol. So
Really?
Back in the 70s and 80s, I think, the number of students who were reporting using alcohol was quite a bit higher. Now, I think that it is the substance most widely used by Ontario students, with 30% of grade 9 students and 66% of grade 12 students reporting using alcohol. Binge drinking continues to be really high. 1 in 6 students report having 5 or more drinks on the same occasion in the past month. Cannabis is among the most common drugs used, with prevalence among 12th graders of 40%. And about 1 in 10 students are have used a prescription opioid pain reliever without their own prescription. We know that. Sorry, say that again.
I said, no, what was that percentage again?
1 in 10.
Wow.
And we know that 75% of them get their first opiate at home.
Really?
Yes.
See, and now, and this is where that's why you're the experts, because and I'm not a big stats guy, but
Dave, don't worry about it.
Well, hockey maybe, but that's really alarming to me.
Yeah, it is.
And
it's
like,
alarming.
With a capital ALARM, because I don't think anybody would deny the fact that there's an issue in the communities, wherever, of this sort of thing. But I'm a little stunned at the moment, really.
Can I give you some good news?
Yes, please.
Okay, so the same survey reports that 42% of students used no drug in the past year, including alcohol and cigarettes.
Okay.
So that's good news.
Right?
Yes, yeah. And that's higher than estimates from even a few years ago, and significantly higher than estimates from the 70s and 80s, right? When 20 to 25% only were reporting abstinence.
Right.
So
the fact that people are doing more because of the pandemic is not true?
Oh, I don't know if I'd say that.
Or sorry, what I should say is, so the pandemic, would you say, has had an effect on those numbers?
I don't know. We won't know until the next one comes out in 2021, will we?
Right.
Yeah.
Okay.
Yeah.
That'll be interesting. We'll have to revisit that and see how, if there's just as alarming with the good news added on the end. Let's go back to that term, concurrent disorders. We sort of touched on it a little bit, but how do you recognize that, and really, what's the treatment for concurrent disorders? Fire away.
Are we talking, Dave, about signs and symptoms? Is that what you're looking for?
Let's start there.
Okay, well, indicators that a young person or child, physical and health warning signs, there's behavioral warning signs and psychological warning signs. But we have to be careful because some of the signs can be also led to just regular other health conditions. So seeing your pediatric or seeing your physician to weed out those symptoms just to get clarification, right? Some of the list goes on and on. For instance, the physical symptoms could be personal grooming, a deterioration in personal grooming, impaired coordination, lots of injuries, and they don't know how they got hurt. Some of the behavioral signs would be drop in attendance or performance at work or school, not wanting to be involved in certain activities after school, missing money, valuables, or even like when we were talking earlier about opiate pain relievers being taken from the home. Well, if you find a lot going missing, that definitely could be a sign. Psychological, definitely your irritability, your mood changing, all of a sudden this increased anxiety, being fearful, withdrawn, anxious, the list goes on and on.
Right. So there's some pretty obvious things, I guess, to look for.
Yeah.
You know, it's not hard to recognize necessarily, I guess. But in the home, are we always looking for it though? Are we keeping an eye out for it as a community, or are we just are we paying close enough attention?
That's a good question. I would like to say with the statistics coming out, that gives us an idea of what we need to look for and what we need to provide for the client.
Yeah. Okay. And then let's talk a little more about the treatment side of things. Libby, do you maybe want to talk about that?
Sure. We, depending on the client's treatment goals, we are wanting to work with both substance use and mental health concerns. However, sometimes we have young people who are coming in who do not want to make any changes to their pattern of substance use. And so that's okay. What we're trying to do, we take a harm reduction approach, and what we want to do is reduce the negative consequences of substance use on their physical health, on their mental health, on their social relationships, and any economic circumstances. So we're really trying to reduce the harm that may come to them. And that may include cutting back on substances or not. It may include abstinence or not. It's all about finding what a healthy future looks like for them, how they can live a healthy life, how they can manage their mental health symptoms, reducing the risk that they're going to return to substance use or that they're going to experience mental health symptoms again, and always looking to improve school and work life and relationships with others. We use lots of different approaches, you name it. CBT, so cognitive behavioral therapy, dialectical behavior therapy, motivational interviewing. We may encourage parents to be in a parent group or to take a middle path. Cheryl could explain more about that. It may involve family treatment. We consult with other professionals like psychology and psychiatry. We have a really close working relationship with Dr. Hussey at Bluewater Health. We collaborate with our community partners like Kelly at Withdrawal Management and Addiction Services. And we're also try to be a resource to parents. So even when a young person is not interested in working with us, we want to work with parents and families to support them, to support their kids.
Yeah, it was important. But not always, it doesn't always work out that way, does it? Like I say, it's the whole lead a horse to water, but
it's true. Yeah.
And then what's the cutoff point when you kind of go, or is there a cutoff point? Like that's tough, right? Because you get attached to that situation and then nobody wants to help themselves. So how do you handle that?
That's a great question. I think that I think that my personal approach is I want to be able to say that I did everything I could, right?
Mm-hmm.
And so I feel like I chase clients maybe more than I chase my concurrent clients maybe more than others. I feel like there may be something that is keeping them from reaching out, and so I'm going to do the reaching out, and I don't mind that. So, yeah. I want to make a difference for that person.
Yeah, very good. We're going to come back to you, Libby and Cheryl, in just a moment, but I want to go back over to Kelly and, talk a little bit more about, okay, so we're getting definitions here on how things work and the process to get started. And by the way, folks who are watching, all these services are free and available. We want to keep reminding everybody that, because I think one of the first things that comes to mind, okay, I recognize I need the help and the services, but I don't have any money. It's okay. You can knock on the doors here. And if you go to St. Clair Child and Youth and that's not the right place, then they'll guide you. And I like that word collaboration that we're hearing a lot here. But Kelly, talk a little bit about the services that are available to the community at Bluewater Health.
Sure. So I'll just start at, so like I said before, we offer walk-in services here at the hospital. So we're located off of Russell Street entrance on the 6th floor. So you can walk in. Our community withdrawal management workers, like myself for today, we're here from 8 a.m. until 8 p.m. So you can literally walk in and come up to the 6th floor. You can either enter through the emergency room department and ask, like, hey, I would like to speak with withdrawal management or somebody about my substance use, or I just need to talk. So oftentimes they will call, and we're here for walk-in services. So we can go to the emergency department and meet them there if that's something that they would like to do, or they can come up to our services and do a walk-in appointment and get things rolling that way. And so sometimes it's just, I don't know where to start. What can I do? And so our first appointment really with the walk-ins is a lot of information gathering and helping to kind of navigate some services for them. So we do walk-in services, and then we also offer community-based scheduled appointments. So often when you come in for a walk-in service, I can schedule you an appointment with myself for your next appointment to begin whatever your treatment goals are. So that may be going to a residential treatment service or beginning community-based addiction counseling as well. So we'll often meet individuals in the community. So community-based appointments with withdrawal management can be here at the hospital, like I said, or they can be within the community. So we can meet in your home, at Tim Hortons, at a park, at the library, wherever really that individual would feel comfortable speaking, because sometimes accessibility, people have lives, and we understand that. So our need, right, is to be able to do our best for individuals and meet them, because we are a community-based program. So we don't want to provide barriers for treatment, so we can meet you within the community. So that also involves going into schools as well, and meeting with youth in schools. We can do that as far as first contact appointments with youth. We also have our residential withdrawal management program, like I mentioned earlier as well. So we are a 7-bed facility currently, and we are 24/7. So I like to really emphasize that we are 24/7. Residential beds. So if at 2 o'clock in the morning and you need to access help, you can call a residential bed, and an intake can be done at any point in time. There isn't a scheduled time of day where you cannot access our services. So you can call for the residential services and come in for our stay with us. And within that stay, it's kind of nice because the community withdrawal management in residential, we're one. So we work in both departments. So it's a less of having to really re-share the stories. And so if we're working in residential, we do an intake the one day, I can schedule you with a community appointment with myself as well. So that wraparound care is really there because it's important to be heard as well. So we have our stay there. So in the residential program, we can begin treatment referrals in-house as well. We offer psychoeducational groups. So we're paired with an addiction counselor or like with a withdrawal management worker and an RPN. So we're a unique program in that facility as well, so which is really wonderful. And then we have our addiction services, where that's where you would begin that intensive one-on-one therapy with the treatment modalities that were just mentioned, like CBT, DBT. We will do like motivational interviewing also throughout that, but a lot of the groups are ran in those treatment modalities. So with addiction services, that's when you would start that intensive community-based addiction treatment counseling. So it is treatment, and so you would begin working. Sometimes it's not the substance use is the first thing that's talked about. It's all the other pieces, because the substance use can be this, but it's okay. So how are you sleeping? How are you eating? Who supports you? What does substance use look like for you? What are your goals for treatment? So it really is like client-centered, focused care with addiction services. And so within addiction services, they also offer group treatment. They offer aftercare treatment if you've completed any residential treatment programming or the group treatment offered here. We have Seeking Safety, so trauma group as well. So that's ran with female and male groups. And then we also offer family support. So we have a family drop-in group, but then we have a 5-week in-house family support group. So those groups currently are being also ran virtual, and that's at the beginning when I talked about how we had to kind of adapt to that need for continuing that treatment care, because group is still continuing, COVID or no COVID. So that virtual treatment was almost like a natural pickup. Okay, this is where we left off, and we're going to continue, whether it's one-on-one, in person as well. So so we offer an array of different.
You can say like it kind of covers. You've covered everything there, which is one of the reasons we're doing this broadcast, right? Is to let people know more and more awareness. This is out there. It's still available, and like you sort of mentioned, Kelly, like just because the pandemic showed up, or I like to call the pandemic someday. Someday. Well, someday showed up. And but the world doesn't stop, and mental health doesn't stop because of COVID-19 or any pandemic for that matter. So it's good. Thanks for sharing all of that, Kelly. Sure. Cheryl and Libby, we're going to talk about the services beyond that are available, but something I wanted to come back to is obviously there's a goal in mind, or an end result that the client's looking for, you're looking for as a supporter. Let's talk about resilience and recovery, and what's that look like?
Well, recovery is a process, and it's lifelong. It could be lifelong, and it includes forward steps and steps backwards, and it's different for everybody. Resilience, Libby, go on.
Sure. So resilience is about being able to recover from difficulties, to function as well as before and move forward. Some people would say bouncing back to in terms of resilience. So bouncing back from difficulties or challenges. We we think that resilience is a really important characteristic, and we want to nurture and strengthen resilience in children and young people. And you asked earlier, Dave, about whether we are. I think what the question was are we doing enough, or are we noticing it? Are we picking up on it?
Yeah.
Right. And so I think that one of the things that we can all work on as adults is to try to foster resilience in the children and youth in our community. There are some protective factors for kids. A secure bond with a caring adult. I know that you guys have heard that before, right? Just one important relationship with a caring adult is so important. It's all it takes. Relationships with positive role models at school, at church, in a cultural organization, that fosters resilience. Opportunities to learn skills like problem solving, anger management, communication skills, all important in fostering resilience. Opportunities to participate in meaningful activities. So being a member of the hockey team, having a chance to paint.
Work.
Those are, yeah, all important protective factors for our children and young people.
Yeah. Now, let's talk about the parents and all of this. I know we're kind of stepping backwards a little bit, but do the parents probably need some support in all of this, because I might feel like I'm a failed parent or a bad parent, or let's go down the list of labels that we put on ourselves, right? Never mind what we think the public might think of us or something, right? But how does that support work through all of this? And what about the resilience? Is there resilience and recovery in this for the parent as well?
Oh, absolutely.
I think it's important to remember that no one chooses to develop an addiction or a mental health issue. Nobody chooses that. The only choice is whether to get help or not. So Cheryl, I know that you've done lots of work with parents around middle path. Do you want to speak to what parents can do?
One thing I tell or I suggest to parents, I encourage them not to blame. Things have happened and let's move forward on this. One thing I ask parents to is don't freak out. That's just going to cause more problems. The kid's not going to know where you're at, even if the kid even thinks he has a problem. Parents need to educate themselves. There's lots of resources, and Dave, I see that you've put up resources. Kids Drug Canada has skits, has videos, has lots of information on how to talk to your kid, what to say, what not to say. And one of the biggest things for me is listening more than talking and validating. We teach that in the DBT Middle Path program for parents. Validation, you might not like what they're doing, but understand why they're doing it. And just to be at their level, that your kids are going to talk if you're listening.
Yeah. So we don't just, don't you do that, that's bad. Just say no.
Right.
And not in my house. And it's hard as a parent to not go into preach mode, right?
Absolutely.
And listening is a skill to be learned for sure. Yeah.
Well,
it absolutely is.
And you make an important, you said something there about parents, and in the parents, we as adults know what life can be like because we've already lived it. So now our kids are living it. So they're going to have to live it, and they're going to go through their things. They're going to do the stuff. They're going to make mistakes. They're going to get into trouble, and we need to be there to support them. And how can we bail them out?
Well, I've always said you don't go through it, you grow through it, right?
You grow through it. Good point.
Oh, interesting. Yeah.
You can have that one. Write it down.
Yeah.
But it's
also,
true, because we go through that where, oh, well, Dad, you don't understand. You're right, I don't. You're absolutely right, kid. I don't understand. Help me understand.
Help me understand.
yeah, so it's good to know that support's there for the parents as well. It's not just, drop your kid off and then come back. Like, and there has to be that, communication, right? It's a skill that can be learned, but it's one that needs to be given more attention to, I think, in all of this, really. Like Libby, you made a good point. Like, nobody chooses to have an addiction. Nobody wakes up and says, I want to do that or that. But it does come to surrounding yourself with the right choices that you make once you do recognize it, right? And Cheryl, I like that you pointed out too that this isn't a quick fix. This is okay. So do this. Like, if we could do that, then we could just, Libby, you could just write a book and hand it out to people and say, do that. And,
right. Yeah.
And we wouldn't be having this conversation here today, right?
Yeah.
So
no. Recovery is lifelong, and it might involve slips and relapses, but it is a lifelong process, and we're all in it.
Yeah. Well, we all get on the treadmill, and then we get off that treadmill once in a while because we feel like this thing isn't working the way we want it to work, or who knows, whatever the reasons are. So let's we're getting close to wrapping up here, but Libby and Cheryl, I wanted to give you one more, just kind of a quick review of what services are available specifically.
At St. Clair Child and Youth Services for addictions or for everything?
Well, just for what we're talking about here today. Okay. Anything else you think that they should know?
So so we have the walk-in, and when we're doing it virtually right now. It's called telephone consultation. And so they can just call intake. They'll schedule that with a worker. If it's strictly concurrent, they'll be calling Libby or myself. So we do have dialectical behavior therapy group. Unsure what's happening with it right now, but I have been doing some middle path work with parents to help understand their kid, how to talk to their kid, recognize emotions, regulate emotions, how to get along. Add on to that, Libby.
I don't know if I can add on. I think the most important thing is if there's a concurrent flavor to what's happening for a young person, they're going to get connected right away, and they don't have to jump through any hoops to get connected. It's a simple phone call.
Yeah, or online at and folks, we're going to be posting all of the links that are available in the comment section below and in the posting below this broadcast. So click on those links and use your devices or whatever. At the end of the day, what I'm seeing here, like, my day, you picked up the telephone or you walked in, but now, like, it's online. Like, there's really no reason to not get in contact with the services. They are out there and not just available, but I like to say readily available, regardless.
At your fingertips. Yes.
Yeah. And, Kelly, you mentioned earlier too about it. 24/7 things are available, and just, I guess, the toughest part in all of this, for whether it's the person who's recognizing it in someone else or that person themselves, is the toughest part in all of this reaching out in the beginning.
Like, that phone is heavy. That phone, right? It's just like getting on that treadmill. Is that can sit there and hold your laundry for a long time before you get on that treadmill. Pick up that phone. It's probably the toughest, because that's vulnerability at its greatest. Is just it's talking to somebody that you've never met, asking, "Can I get some help?" and being told yes, and it's like, okay, now what?
We're kind of used to, like, if somebody asks you for help, you feel good. You go, well, somebody asked me for help, but it's harder to ask out for help, right? And we're kind of worded that way, right? And
it takes a lot of courage. Absolutely, it takes a lot of courage to reach out.
Yeah, I think it's fantastic, really, and coming through, and some I've known before all these podcasts, but I've learned so much through these video podcast, the Mental Health Show, and learn so much more about what is available that I didn't. I guess sometimes too, it's partly because if you don't have the issue, you don't necessarily look for the services, obviously, right? So, but this creates some more awareness. And, how do you, one thing I've always wondered too, like, okay, we can see it as a family and we recognize it in our youth, but what about a neighbor? What about a neighbor or a coworker that recognizes something that can be a little more, or we can feel like we're being a little more intrusive if we try to help? Is that fair to say?
Maybe, but I think let's not allow that to keep us from reaching out. I think that the people who have expressed care to me in their lives are ones who may not have been close friends to begin with, but maybe became close friends because they expressed care for me, right? And I think that the best way, I don't know, I think some of the best words that we can say is, how are you doing? Are you okay?
Right.
You seem off, right?
Yeah.
What can I do for you?
Open up the conversation.
Can I give you a ride? Yeah.
Yeah. Well, I think especially right now, and I've said it a few times, probably say it some more, when we ask somebody, how are you doing? It's a whole new meaning right now.
Mm-hmm.
We're going, oh, hey, how you doing? It was just something we said. Great information again, ladies. I know I've got something special here we want to close with that I'll share. But first, I want to give everybody an opportunity to any final words. Kelly, I'll start with you.
Sure. So just to kind of go back to that, being able to reach out for services where the phone sometimes is difficult to pick up. Email. So we have an email address that you can email us at. So it's possible. So POSSIBLE at bluewaterhealth.ca. So you can send us an email any time of day, and it goes directly to addiction services, withdrawal management, and we can respond via email. Sometimes things are easier to ask over an email than they are over the phone. So we're here to provide that support. And then we also have a hope line where you can call directly, and that's answered daily with return calls. So that phone number also, 519-332-4673, or HOPE. So you can always call, leave a message, and we will get back to you for that.
And we'll be sure to share that again on the comments below for those of you who are watching. Kelly, thank you so much for being here today. Cheryl and Libby, will come back to you. Cheryl, any final thoughts and words?
Well, when we talk about neighbors and things like that, if a young person is functioning in their lives, they may not recognize that there is a problem. But we as adults, we have the experience and we may recognize the problems. And I think that going one step beyond just sitting at your front porch, take a walk over and say, hey, what can I do for you?
Mm-hmm.
That's a good
What
point.
weather we're having.
Yeah.
Very good.
About COVID.
Right. Libby, what about you?
I don't think that I have anything else to add. I really appreciate having the opportunity to talk about what we do. So thank you for inviting us on the show.
Yeah, well, fantastic to have you all here. And again, great information. Before we go, folks, we do have a special poem here that we want to share. And I think this came from Clair Child Youth Services. From all I have known and all I have seen, every single being and each thing recovering from someone or something, right? That's a great statement in there. And again, thanks to all of you for being here today. Really appreciate. And again, for those of you who are watching, the links are going to be in the comments and description. Try to make that phone a little lighter. Just reach out. People want to help. And one of the things I can say is I've known a lot of the people that we've had, and I can tell you they're very sincere about what they do. This is beyond a job and a career to these folks. And you're in very good, heartwarming hands. My name is David Burrows. I've been very happy to be host of the Mental Health Show. We'll be back again next week. If you've got any ideas for topics that you'd like to be seen here, again, in the comments section below. Until next time, Take care of yourself and each other, everybody. Bye for now.